Dr. Dhillo sir, Dr. Ramakant and Dr. Sudeep Kumar to please come on stage for the discussion. So this is a case which came about 2 months back. He's a 58-year-old male presented with pain over left hip region and groin difficulty in ambulation for last 3 months. There is a history of neck of femur fracture with hemi replacement hip arthroplasty done outside about 3 years back. Now, the local examination skin condition was normal and this scar was, healed. Local temperature was normal, range of motion was normal. There was no D and VD and other joints were normal. So, we got this X-ray. This is the immediate post-op 3 years back X-ray. So this appears to be a bipolar good joint done somewhere outside. Now after a symptom-free period of about 2 years, the patient has developed anterior thigh and groin pain. ESR CRP, which was done sequentially, was within normal limits, and we got a bone scan done, which was suggestive of aseptic loosening of the stapler component. We did a hip arthro aspiration, which was dry. So this is the recent X-ray of post 3 years post hemiarthroplasty. Dr. Ramakant, what would you suggest to be done in this?
Hello. I think this is 53-year-old lady, right?
Yes.
So this is 58.
The 58-year-old, the 3-year-old, yes.
Yeah, so this is too early for a bipolar. I mean,
that is true. That is correct.
So you are saying that you have ruled out all. I mean, infection. You have done bone scan. So it's a
So initial the ESR and CRP were within normal limits. We did a sequential ESR CRP, and we have checked for the last 3 years. The patient has on and off pain in the anterior groin pain, but he was by and large symptom free for about 2 years. And post 2 years, like from 2019 to 2021, he was okay. Between 2021 and 2022, he had developed this pain. And from outside, they have got ESR CRP, which was normal. Skin was normal. There was no range in temperature. The range of movement was okay.
But she's having pain.
But she's having pain.
So I mean, if you ruled out infection,
we got a bone scan done, which showed that there is an aseptic loosening, and we did a aspiration from the hip, which was dry.
okay. So once we have ruled out all I mean aspects of infection, then I think it's a simple case of acetabular erosion or acetabular loosening. I mean, so we have to revise the hip.
Yeah. Basically, see, from my point of view, I'll just not rule out infection as of now. See, looking at the lysis which is happening, either it is the cartilage which is getting lysed because of the bipolar being done too early, and patient may be very highly mobile and active. But still, and there is a lesion at the, just at C lesser trochanter, there is a lesion as well. You got a pointer. I think the bone is not looking great there as well. Though stem has not subsided, I think, if I'm 100% not sure, but then the last X-ray didn't show any subsidence of the stem. Though there is some lysis here, if you can see on the other view, but then probably I'll not rule out the infection. I'll keep my mind open for a 2-stage revision. Probably I'll not go for a 1-stage revision. Definitely this needs a revision, okay?
Dr. Lilo, sir, what's your take on this?
One should take perioperative samples also if there is a infection. If on the naked eye there is no infection, even then one should take sample from the acetabular floor just to rule out any
Yeah, so the house says that we need to operate this patient, but you have to keep in mind that intraoperatively finding will determine the kind of operative intervention
Yes,
that
but
you
you
will
know the
perform.
intraoperative finding is very subjective. So you have to be very, very careful when you're going. If you go with a very close mind, so you have to you have to actually go with a very open mind and with a fixed plan. You just cannot go that I'm going to do a one-stage revision. Probably I'll never go with this. I'll definitely go with a two-stage plan because no matter what you do, you can always, and you never know that patient may be allergic to the metal.
Absolutely.
You never know. So you may
Yes,
need to test
metallurgy
that
is-
as well. And if you put in the next stem, or suppose this seems to like a coral stem, which is well-fixed stem, why there is a lysis at the lesser trochanter lesion? So probably for me,
So yes, so if you look at this X-ray, the superior margin, the weight-bearing margin of the acetabulum looks, there is a big lysis over there, and probably this is the cause of the pain in this patient. There is, of course, there is a little bit of lysis in this in the greater trochanteric area also. So that's another area of contention. So we did an diagnosis of aseptic loosening in this patient, and could be a infected bipolar. So the treatment plan we decided we either will go do a single stage or a two-stage revision surgery. So that's the area which was contentious in terms of the lysis and which was causing the pain. So intraoperatively, we did go and we found that there was plurulent discharge in the area of the acetabulum. It was absolutely plurulent, but the problem was the stem was pretty well fitted, so it was very difficult to take out the stem, and we did a thorough debridement with betadine and saline wash, and then we put an AMP antibiotic imperimental cement spacer in this patient. So this is the post-op we did in this case, and we plan to do a follow up this patient further. So next patient is another patient, which is the 48-year-old male patient presented with pain over right hip region for 1 year. First discharge from right hip region for 1 year, and there is a limp and shortening of the right lower limb. There is a past history of 1 year back. He had a acetabular fracture, for which a THA was done somewhere else. So on examination, this patient had discharging sinus, local temperature was raised, all signs of infection was present. His movements was restricted with flexion 10 to 80 degree, extension was completely absent, internal rotation was absent, external rotation was 10 degree, abduction, reduction 10 degree each. Limb was approximately 2 centimeters shortened, and there was no DNVD. So we did an ESR and CRP total WBC count, which was raised. Serum electrolyte was normal. We sent a pus culture, which showed growth sensitive to piperacillin, tazobactam, cephalosporin, sulbactam, and meropenem. Now this is the X-ray. Dr. Dhillon, sir, your take on this.
This is very difficult to take out the implant. Yeah. So first is challenge to take out the implant.
you may have to plan, go anterior. Actually, intrapelvic approach need to be done because to pull this out in this case may look easy on the X-ray, but I'll tell you, we have done that once and it's not easy. So we have to open it anterior and we have to take out the implant, the head part and the cup part from inside. Because the more you try, the more damage to the central part you will do. So first taking out the implant, of course it's going to be a two-stage and other than X, Y, Z after that, but first is taking out the implant. You have to be inside. And
so I must tell you this, that we did not get anything more than an X-ray from the previous records. So this was the only X-ray, the recent X-ray that we got, and this is the only record that was available to the patient.
Absolutely fine. See, everything is clear that you have to do something for this patient, and for doing anything, you have to take out the implant, isn't it? So you have to take out the, what I'm trying to tell you is that taking out the implant, suppose it was done from a posterior approach, it's not be easy to take out the acetabulum part. So you have to
Why,
go
sir? Why do you think
intrapelvic.
so?
Sorry?
Why do you think so?
See, it is inside, okay? It's
Okay.
like and everything will be contracted and you just cannot pull everything out. And you can damage actually more while pulling it out, neurovascular and everything, than just going intrapelvic and taking out the everything very calmly and quietly. So,
I mean, certainly in this case, you have to involve a pelvic surgeon and general surgeon. I mean, It's not very easy to remove the implant, and there will be lots of adhesion inside the pelvis. So the priority here is implant removal. Then it can be managed as a, stage-wise revision THR.
Okay, so any investigation, further investigation you would suggest before, in the pre-op planning?
I mean, you should get a contrast CT done to see if there is anything, any involvement of how close is this with the neurovascular bundles, how thin your artery is.
You want to say CT angio?
CT angiography or contrast CT, just to
Absolutely.
see
Absolutely,
how
yes.
close you are, where actually you're going, where your screws are. So that is important. It may be rotated and just hitting. So our pseudoaneurysm might have been formed. So you have to be very close when you're pulling these implants out. So get a CT angio done.
Yes. So this is a 1-year-old history, and the patient already had this implant in situ, and we did not know when this fracture was happened. And if you notice this is not a bone. This is a mesh cage somebody has put to cover the floor. So, and that has migrated inside the pelvis, and taking it out, because in 1 year the mesh, we don't know what kind of addition the mesh have caused at that point of time with the screws inside, and what the screws, positioning of the screws in one of the screws looks like it is inside the bone. So taking it out would be another difficult part. Now taking the hip, dislocating the hip was another challenge for us, but because the patient had infection, it was loose and we could dislocate the hip in one go. But we, absolutely right, we did got the CT angio done to look for the adhesion, and then we found out that the superior gluteal artery is just next to one of the screws. So we were very, askance about the approach, whether to go in and do a posterior approach or go and do an anterior approach first and dissect the complete wound and then take the implant out. But we finally decided to go through the posterior approach. This is the CT film, CT angio films. I am sure that you would be able to appreciate the kind of mesh over here, which is there, which was not very evident on the X-ray. So you see this is the mesh. So we got the CT angio done, and 1 day prior to the surgery, we got the embolization of the superior gluteal vessels. And what we did is we dislocated the hip joint, as Dr. Sudeep sir said, and because it was loose because of the infection, we put 2 cockers and held the cup of the acetabulum, and we made multiple drills in the insert. So if you make multiple drills, the insert will come out, and then you can take the insert out. The difficult part was with finger we tried to dissect, and we were lucky enough to take the mesh and the screws out. So, and then when we did this first stage surgery in this. So the take-home message is any revision surgery or any infected, it looks like non-infected, but you have to always keep in mind that you may have to do a first stage, and not only that, you have gone to the surgery room and then you have to do a complete revision on that table only.
Did you fracture the GT while pulling? This wiring is for what? GT fracture?
Okay, so when we were taking out the stem, there was a fracture of the greater trochanter. We did then in circlage for that.
You did not use any intrapelvic approach. You just pulled the implant from posterior approach.
No, we did not go ahead. We were lucky because for the stem we did not have to go to the posterior.
Options have to be there.
Absolutely, we were absolutely ready for that. That's it. Thank you. Thank you, sir.
We are still waiting